Hi everyone, welcome to Thymus. We're your med school advisors
and personalized study buddies.
So today we'll be talking about primary and secondary endocrine disorders, and I will be talking about two hormones in particular, the parathyroid hormone and cortisol. Starting off with parathyroid disorders, here are some general pointers regarding parathyroid hormone. It's released by the chief cells of the parathyroid glands, which are derived from the endoderm of the third and the fourth pharyngeal pouches. It takes part in calcium homeostasis, and it works by utilizing the cyclic AMP pathway. Now moving on to primary parathyroid disorders. Anything primary has to do with the gland itself. Hence, primary hyperparathyroidism would be due to the oversecretion of parathyroid hormone from the glands. There could be a number of causes, but the most common ones are an adenoma or parathyroid gland hyperplasia. Clinically, you will see a patient presenting with calcium oxalate stones due to increased serum calcium. Calcium in the blood also causes an increased secretion of gastric acid by activating gastrin, so this can lead to peptic ulcer disease. And the patient can also present with osteitis fibrosa cystica. Primary hypoparathyroidism, however, is due to the undersecretion of parathyroid hormone from the glands. This also has a number of causes, but the top three are autoimmune destruction of the glands, thyroid surgery, which can damage the posterior part of the thyroid gland, leading to damage of the parathyroid glands, and DeGeorge syndrome, which is a genetic abnormality in which the third and the fourth pharyngeal pouches do not develop properly. Clinically, you will see a patient presenting with tetany, which is due to low serum calcium. You can test for low serum calcium by looking at the positive results of two signs, the Schwastek sign and the Trousseau sign. And patients can also present with cataracts. So I know labs can be very confusing for endocrine disorders, and these are frequently tested in exams. Hence, I've made a table to simplify it for you. Let's take a look. As you can see, in primary hyperparathyroidism, serum calcium increases, serum phosphate decreases, and parathyroid hormone is obviously raised. In hypoparathyroidism, serum calcium is decreased, serum phosphate is increased, and parathyroid hormone is obviously low. Here's a hack that I'd like to share that really helped me get through this topic. In any primary disorder, calcium and phosphate move in opposite directions. Let's go back to the table and see how this applies. As you can see, in primary hyperparathyroidism, calcium is high, phosphate is low. And in hypoparathyroidism, calcium is low and phosphate is high. In any primary disorder, calcium and phosphate move in opposite directions. Now we're going to talk about secondary parathyroid disorders. This is when the glands are working fine, but there is a secondary problem at hand. Starting off with secondary hyperparathyroidism. The two most common causes are chronic renal failure, and this is because there's a decreased excretion of phosphate from the kidneys. The phosphate in the blood binds calcium, hence serum calcium levels drop. In response to low serum calcium, the parathyroid glands release the parathyroid hormone. Patients can also develop renal osteodystrophy. And the second most common cause is vitamin D deficiency. Next, we have secondary hypoparathyroidism. And this is caused by two things in particular. One, vitamin D toxicity. And the next one is very important from an exam point of view. You have magnesium deficiency. And this is because magnesium is a cofactor for adenylyl cyclase. And if you remember that I mentioned before, the parathyroid hormone works through the cyclic AMP pathway. Hence, magnesium deficiency will cause hypoparathyroidism. Just like the primary disorders, I've drawn up a table to make the labs easier for you. And don't worry, there's a hack for this too. Let's take a look at the hack. So it says, any secondary disorder will have calcium and phosphate move in the same direction. Now there is one exception though, which is renal failure. And in this, calcium and phosphate move in opposite directions, much like a primary disorder. Let's take a look at the table below and see if the hack works. So if you look at secondary hyperparathyroidism, which is vitamin D deficiency, calcium is low, phosphate is low. Same direction. If you look at the hypoparathyroidism rows, you can see that calcium is high and phosphate is high, same direction. Let's take a look at our exception, secondary hyperparathyroidism, renal failure. And in renal failure, you have calcium going down and phosphate going up, opposite directions. The hack works. Now we'll talk about cortisol disorders. Here are some general notes about the hormone itself. Cortisol is released by the adrenal cortex. It's a stress hormone. It's catabolic. It's an immunosuppressant because it inhibits phospholipase A2, and it increases bone breakdown. First, we'll talk about primary disorders, as in something is wrong with the gland itself, in this case, the adrenal gland. Let's start with primary hypercortisolism. This is most commonly due to a non-cancerous tumor of the adrenal cortex, also known as an adrenal adenoma. The adenoma secretes cortisol, and due to negative feedback, serum ACTH is low. Clinically, the person presents with muscle weakness, moon phases, buffalo hump, hypertension, and osteoporosis. On the side, there's a diagram showing all the clinical features of a patient presenting with hypercortisolism. In primary hypocortisolism, we have adrenal insufficiency. There simply isn't enough cortisol. If it's an acute cause, it could be Waterhouse-Friderichsen syndrome, which happens in children after a meningitis infection, and it leads to hemorrhagic adrenals. If it's a chronic case, it could point towards Addison's disease, which is the autoimmune destruction of the adrenal glands. Patients with Addison's disease can also present with hyperpigmentation, and serum ACTH is high. Now let's talk about secondary disorders. This means that the gland itself is working properly. There's a secondary problem at hand. Secondary hypercortisolism. Now, there are three main causes for this, and each of them are very important and frequently tested on exams. Number 1, Cushing disease. This is an ACTH secreting pituitary adenoma and leads to the bilateral hyperplasia of adrenals. Now, I know a lot of people are confused between Cushing's disease and syndrome. Hence, I've drawn up a table to simplify it for you. Cushing disease is the specific term that you use for an ACTH secreting pituitary adenoma, whereas Cushing's syndrome is a general term you use to label any patient with hypercortisolism, regardless of cause. It could be any cause. The second cause could be ectopic ACTH secretion. This is most commonly due to a small cell carcinoma of the lung, and patients also present with hyperpigmentation. And then you have exogenous corticosteroid use. Labs are very important for this topic as well, and they can be really confusing. So I've drawn up my own chart just for you. As you can see, first you do a low-dose dexamethasone test, which is usually 1 milligram overnight, and you measure the patient's serum ACTH levels. If they are suppressed, that means that it could be exogenous corticosteroids or an adrenal adenoma. If serum ACTH levels are not suppressed, you then want to find out what cause could it be. So you do a high-dose dexamethasone test, which is 8 milligrams, and you measure the serum ACTH again. If the high-dose dexamethasone test shows suppressed levels of serum ACTH, that points towards Cushing's disease, which is an ACTH-secreting pituitary adenoma. And if they're not suppressed, that automatically tells you that it's an ectopic source of ACTH, which is most likely a small cell carcinoma of the lung. It's very important to understand this chart. Feel free to hit pause and take a screenshot. And that concludes today's topic. Thank you for watching. What would you like us to cover next? Comment down below. And don't forget to like and subscribe.